So we will continue on talking of topics concerning instability and labral tears. And so let's turn ourselves to inferior area. We've already seen a few pathologies in this area. So in this area, we can see inferior dislocations, which can produce inferior labral tears, Hegel lesions, humeral avulsion of the glenoid ligament, inferior glenohumeral ligament from the humerus. We saw one of these yesterday. Reverse Hegel, a gaggle, and a glenoid labral articular disruption, which we've talked about before. So here's a PD FATSAT image. We can see it's with an arthrogram, and down here we can see some increased signal intensity abnormality of an inferior labral tear, which we can see right there. And if we do the ABRA view, we can actually see in this location. But one thing I want to remind you that there can be a confusion, and I don't think I talked about it enough in our initial lecture on the shoulder, but that the glenoid can be rotated or is typically rotated in the sagittal plane or the oblique sagittal plane. And what's straight inferior on a typical MR image is actually more anteriorly and inferior on the actual anatomy of the glenoid itself. So if you're in the anterior aspect inferiorly down here, this is more of an anterior-inferior tear because of kind of the rotation of the glenoid in that sagittal plane. So here's a typical inferior labral tear, as you can see here. Let's see. Somebody just joined us. Let me see who just joined us. Okay, Sam, what do you think of this case?
I think that in this case, this is probably a real tear. It looks like there's a paralabral cyst, loculated cyst.
Okay, so we see a linear increase signal intensity going through the base of the inferior labrum, and then we can see that there's fluid collection next to it. Now, these paralabral cysts like this may or may not communicate when you do an arthrogram. You have to be very careful. It's one of the reasons why you have to have more than T1 FATSAT images when you do an arthrogram. Since a large number of these don't communicate at the time you do the arthrogram, you can completely miss the paralabral cyst if you don't have a fluid-sensitive images. I don't think that's a problem here at RadNet, but I've seen a surprisingly large number of studies that I've had to review from the outside that have only had T1-weighted FATSAT images in all three planes. I guess there are people trying to save money on sequences, but that can be very dangerous. Here we can see the ABRA view, that tear, and notice that ABRA view, you might say this is anteriorly, but considering the position of the shoulder when it rotates a little bit, this supposedly anterior position on the ABRA view, this is really posteriorly, superiorly, this is really anteriorly, inferiorly, and that's a typical location of a lot of tears. And that's really more inferior. Here's just another example of the same thing. Tear, you don't see the tear real well, but you can see the signal intensity going through there, and then the paralabral cyst is really a good indicator. And if I only see a paralabral cyst, and I can't really see the tear itself, I'll still describe the cyst and say that they're highly associated with tears, and a tear can't be excluded in that setting. And then we can see it going down the quadrilateral space in this particular case. And just remember, sometimes these can become large enough where these can actually put pressure effect upon the nerve, and you can get denervation syndromes due to these quadrilateral space cysts. Okay. Thomas, what do you think of this case?
78-year-old female, right shoulder pain for 4 months, electric shock-like pain. Because I'm not seeing an image on this slide. Okay. So axial, coronal, sagittal, and yeah. So there's denervation hyperintensity of the muscle, and there's a paralabral cyst.
Which muscle is this?
So I think that would be
So you're probably talking about
teres.
teres major and latissimus dorsi. In this
Okay.
patient, often they're both involved. This is probably more the latissimus dorsi, but right. So so when you see large paralabral cysts, especially in areas where you know they might involve the nerves, it's important to take a second look at the muscles that may be involved. Okay, good.
It's a triceps.
Good.
Did you read that? It says denervation of the triceps.
Oh, I was wrong here.
Yeah, I think it's triceps.
Yeah, I think you're right. I think this is the triceps. Right. Sorry, this is the triceps. Good. Yep.
It's not easy to tell sometimes.
Yep. So down in this area,
especially in small images.
yeah, since pathology down in this area is relatively uncommon, I generally, before I issue it in a report, I will confirm the anatomy in an atlas. And then here we can just see that's where the cyst is, and that's the denervation syndrome involving the triceps in this case, as you see that it actually attaches to the scapula. Okay. Okay.
Okay, there is increased signal in the inferior labrum. Looks there's a tear, and we have some fluid in the axillary pouch. It doesn't look like a cyst. I think they just have an inferior labral tear.
And what's that low signal there? So maybe you can see a tear here. What's all this stuff?
So, is it acute?
An axial image showing signal below the equator, so you shouldn't have signal at the base of the labrum there. When we go inferiorly there, we have this.
Oh.
So that's actually just a flap tear, and that's a piece of the labrum hanging off there in the contrast. Okay. Sam.
Sorry, can you show the last, not the last one before the last image? Wait, so that's but okay, I guess there's a piece of labrum missing there. Doesn't look like it so much. All right.
We're not imaging the place where it's missing. This is where this is the displace component.
Oh, I see. Okay.
This is the
Gotcha.
place where it's missing.
Sam, what's the prognosis for? Sam, what's the prognosis for that patient?
I would think it's good. I mean, it looks sharp and everything. I imagine you would just take it and tack it down.
Yeah, it's awfully young for a lesion like that. He's going to have problems for long until the end.
Yeah.
But you would treat that surgically, and it would be okay, right?
Most people would treat it by.
It's kind of sad to see these.
Yeah, most people would treat this by resecting the unstable fragment, though a lot of people will try to repair it. But repairs of labral tears like this tend not to survive.
There's this tear again.
It's the same one. So it's
that's the problem.
Yeah.
Okay.
Hey, Sam, what do you think of this one?
This fluid or trait or contrast, I think outside the joint space. I think probably a avulsion from the humerus of the inferior glenohumeral ligament, the Hegel.
Okay, so the tear of the inferior glenohumeral ligament or the inferior capsule.
Yeah, I wonder if that's edema in the lateral head of the humerus, in which case I would wonder about an inferior, the two of them together, I wonder about an inferior of the vertical transient dislocation.
Okay, good. Then this is all that edema down in the soft tissues. You see part of the tear is extending anteriorly. That's the edema within the head. And this is a Hegel lesion with a little bit of herpes due to an inferior dislocation of the humerus. Good. Excellent. Tom, what do you think of this one?
29-year-old male skiing injury. 1 week ago, evaluated for rotator cuff tear and there's fluid, I guess, inferiorly, and there's discontinuity of the inferior glenohumeral ligament at the humeral attachment.
Well, the humeral.
So this would be.
This is the humeral attachment, right?
Okay, so then you'd be closer to the axillary pouch.
Yeah, and then so down here we probably see a little bit of coming off the glenoid here, and we see the bone injury. So what do you think caused the bone injury?
It's in the greater tuberosity.
Well, it's an impaction injury, either it's a direct impaction or you have an inferior dislocation, probably with the extended arm, with impaction against the inferior glenoid. So this could be an inferior dislocation, or it could have been a direct impaction injury with displacement, which tore the cuff. So it depends upon the position of the shoulder at the time of the injury. And then we can see that there's some abnormality here of the inferior labrum with linear signal going through it. So this, however, was an inferior dislocation causing a superior heel sacs with an inferior glenohumeral ligament tear. And this tear was really kind of a tear through the central part of the capsule and the ligament, rather than an avulsion off the humeral head. Okay. So what do you think of this?
The avulsion is from the humerus, isn't it?
Well, in this case, oops, go back here. In this case, the humeral attachment, John, here, I think is intact. I think that inferior glenohumeral ligament's abnormal. I think the tear is out here. And I think some of the glenoid attachment is intact. So this was, I think, kind of a mid-substance tear of the capsule down there.
Okay.
Okay, again, we have tear of the inferior capsule. I see the glenoid attachment wall, but again, I think it's mid-substance probably, or humeral, two humeral attachment.
Very good tissue here. Mm-hmm. My guess is that this probably fits up here, and so this would be more humeral in this case. And then we can see there's a tear of the rotator cuff as well. And then what about all this bone injury here?
So we have impaction injury of the lateral humeral head.
So what's the mechanism?
Again, it can be direct impaction injury, or it can be like a vertical dislocation.
This was an inferior dislocation. Okay. Yeah. Normal or abnormal, Sam?
Abnormal.
Good.
Looks like in the last few, I guess, just before it relocated.
Slightly abnormal or big time abnormal?
Painfully abnormal.
Yeah. How they got this person to get a scanner, I don't know. But
how would you like to operate on this?
I wouldn't like to operate on anyone. I send them all to you, John.
I don't want to operate on this one.
Okay. So, Sam, what do you think?
So it's an inferior dislocation impacting into the little head.
So you can really see the mechanism of injury here pretty nicely. Mm-hmm. In this case, we also have a lot of rotator cuff tears.
Yeah.
Yes. And then here we see the empty fossa here due to the dislocation, and then on the sagittals we can see the humeral head down here before. So that's an inferior dislocation. On X-rays, this, John?
Motorcycle?
This one is. This is a different patient. And the MR scan after they relocated this patient. So, Thomas, what do you think of this case?
So there's anterior-inferior dislocation of the humeral head. And on MR,
it's been relocated.
It's reduced, and I'm not seeing there's some areas of low signal intensity at the axillary pouch.
Yeah, there's this.
Yeah.
But what do you think this thing was?
So that could have injured one of the. I think it's either one of the glenohumeral ligaments or the labrum.
So in this location, it's either going to be, well, it attaches up here, right? So this has got to be either the middle glenohumeral ligament, which is torn, or it's got to be
Right.
superior insertion of the anterior band of the inferior glenohumeral ligament, which is torn inferiorly here. We'd need the other images to sort out which of those two it is. And this is probably a loose body down here.
Okay.
Have to look for a donor site in that patient. Here's a hyperextension injury playing basketball, and here we can see a typical Hegel humeral avulsion of the inferior glenohumeral ligament from playing badminton. What else do we see here on these images, Sahar?
Okay, so we see hypointensity in the joint. Those are like, I think it's hemorrhagic like fluid in the joint space.
So we're seeing all these low areas of low signal intensity, and this is something that's very unusual. Generally, the general rule of thumb is you never get a clot within a joint space. And the reason is that if you hemorrhage into joint fluid, the fluid disperses the hemorrhage and the clotting factors aren't concentrated enough to be able to obtain a clot. What this shows is very rarely, if you have enough hemorrhage, it doesn't get diluted sufficiently where you can actually get clot within a joint space. And this is very rare, but this is an example of that occurring.
That's because it's a humeral avulsion, right?
Yeah, I think so. And there was a lot of hemorrhage there, right?
Because the labral tears don't bleed.
Mm-hmm. Right. Okay, Sam.
Okay, I think the humeral attachment of the inferior ligament is attached here also, and a lot of abnormal signal. It's taken, but aside from that, maybe is it T1?
Probably.
Okay, so then that's edema and greater tuberosity. So again, probably attached a bit on the inferior glenoid. Yep.
You got to watch out bike riding here.
Tor
Front rotator cuff.
Mhm.
And we can see a lot of labral injuries due to this dislocation also. And got a bunch of different findings, which you can see nicely with. Thomas, what do you think of this case?
So it's an axial view. Looks like the posterior joint capsule is torn with a joint fluid extravasating posteriorly.
So this is posteriorly. So this would basically be the inferior glenohumeral ligament, the posterior band of the inferior glenohumeral ligament or capsule. And it looks like it's probably been torn off the humeral attachment there as well. So this is often called a posterior Hegel or a reverse Hegel, which I always think this is, most people call this a reverse Hegel, which I think is a little bit confusing because if you said a reverse Hegel to me, I would think, well, that probably means it's torn off the glenoid rather than the humerus. But a reverse Hegel really just means it's posterior rather than anterior, which is less common. The more common one is the anterior Hegel.
Okay, we have tear of the inferior glenohumeral ligament from the glenoid, actually.
So you're talking about this time?
Yeah, looks like the inferior capsule is torn.
So this is an inferior glenohumeral avulsion from the glenoid, and a lot of people call this a Gagel lesion. Again, I really prefer describing where the tear is, but a lot of people like these acronyms, which personally I find kind of confusing sometimes. But you'll hear the term Gagel, and that's what this means. Okay, Sam, what do you think of this case?
There's a fluid collection under the glenoid. I think the inferior glenoid ligament is intact, isn't it?
No.
It's not intact. So then, so you know what? It's an avulsion. It's maybe another glenoid avulsion. If that's a piece of bone there.
Yeah, this is inferior avulsion. It's hard to say on these whether there's a piece of bone or not. But these inferior gaggle lesions, or these gaggle lesions, almost always involve the inferior labrum as well. And I think what we're seeing here is just a tiny remnant of labrum left, and it's really a tear through the labrum and a tear through the periosteal attachment, and then you've got this perilabral cyst.
What is that hypointense line connecting the avulsed fragment to the glenoid?
So this is the
Not that.
perilabral cyst. This is the perilabral cyst. Why is part of it bright and the other part not?
It's contrast, probably concentrating in part of it, or maybe diffusing its part of it.
Right. So this becomes very thick and viscous, and the contrast in this arthrogram only diffuses into the less viscous portion. If you came back and imaged them a day later, you'd probably see contrast in the remainder of it as well.
But there's a thin line more laterally at the edge of the cyst laterally. What is that?
That's just remnants of the labrum that are deformed after the tear.
Okay. Yeah.
The capsule stops here. This is all labrum, periosteum, and potentially bone in this area, but usually there's not bony. This is usually just all labrum.
Mm-hmm. Thank you.
Right? Thomas, what do you think of this one?
So there's a tear of the inferior glenohumeral ligament, basically from the glenoid. So this would also be a gaggle with edema of the humeral head.
Yeah, so it also looks like there's probably an inferior dislocation here as well, though it could just be a direct blow. And then we can see that the tear of the labrum here, tear the capsule off the glenoid side, and we can see the tear extends anteriorly and posteriorly on the more superior images. So an extensive injury, probably from an inferior dislocation. Okay.
Okay, 39-year-old man, underhand ball player, right shoulder pain, worsened overhead motion following trauma during a match. So I see some irregularity of the inferior glenoid. Right there. So I'm concerned about like. Okay.
So you want an MR, right?
Yep. Sure. Okay, so there's some hypointensity along the inferior glenoid. I think the inferior glenohumeral ligament. There's some increased signal within that too. Maybe like a chronic gaggle lesion with interval healing. Okay, triceps lunkhead. Okay, we have chronic tear of the triceps also. Looks very thin now.
Here, there's the axillary nerve. Now this is that
Atrophy of the teres minor.
Teres minor, and then so there may be involvement here of the axillary nerve, which may lead to the teres minor atrophy. And then this is the area of the axillary nerve in here. So this was a chronic injury here, which led to scarring and involvement of the axillary nerve. And that the bony irregularity was some avulsion of a piece of the bone off inferiorly, which in this case led to a denervation problem with the axillary nerve. Okay. So let's move on to the superior labrum. This area, some people have called microinstability, involving the superior labrum and the middle glenohumeral ligament. And this is the term SLAP was originally coined by Dr. Snyder here in the San Fernando Valley, and it became a real hot topic about 10 to 15 years ago. Wesley Nottage from the Orange County really talked about microinstability. Yes, John?
My old student.
Ah, really? Oh.
Yeah, he was actually interested in knees.
Snyder?
And then, yeah, then with arthroscopy coming around, then he got excited about shoulders.
That's Steve Snyder?
Steve Snyder, yeah.
Yeah, I think he worked with Jim Fox, who was a knee person who making up.
Yeah, he was with Fox.
Yeah.
Well, he was. I don't think he spent any time at Scully. Was Fox and Marty Blazina.
Yeah.
And
Well, they started.
I can't think of the other guy's name.
They started Scully, didn't they? In the Valley.
Then Marty got in a hassle with the younger guys, and he went on his own.
Okay. Right. So then, okay. So let's talk a little bit about microinstability. It really has to do with cuff disease in the superior area of the shoulder. And you don't get frank dislocation with this. You get a lot of easy fatigability due to subluxation, and you can get a lot of pain in the parascapular region. And really, the instability up here leads to impingement type symptoms. So part of this complex are superior labral anterior posterior tears, superior labral detachments or slack, superior glenoid ligament laxity or tear, middle glenohumeral ligament detachments, which are pretty uncommon. I think we've already seen some tears of the middle glenohumeral ligament, and articular partial thickness cuff tears, kind of in this category. In this category, the thing that's gotten the most attention really are slap tears. And if you look in the literature, there are a number of papers describing different classifications of the slap tear. And personally, I think that, again, this is an area where I would describe the findings rather than the type. But let's go through each of the different types because you'll hear the different types. Now, Steve Snyder, John's protege, really described the first four types of slap tears. And still, most of the shoulder surgeons that I work with only recognize the first four types of slap tears. Most of the rest of these were described in the radiology literature by radiologists and really aren't important from a clinical standpoint, though some people would disagree with that. The superficial tear, or type 9, was described by an orthopedic surgeon in Santa Barbara. And then superior tear extending to the interval was described by a radiologist on the East Coast. But anyway, let's go through what some of these look like. Oh, this is kind of the nomenclature. Now, superior, the standard nomenclature assumes that if you take the oval of the glenoid, it's pointing straight up. If you notice here that the acromion process here is posteriorly and superiorly. So if you look on an MR examination, this whole diagram here is actually going to be rotated about 30 to 40 degrees in this direction, so that the acromion process is on top. That's what we normally see when you do an MR scan. The top of the glenoid where the biceps attaches is going to be anterior superiorly, and the inferior area where the triceps attach and so forth are going to be posterior inferiorly. But classically, you should describe the locations around the glenoid with the biceps insertion at the 0 position, and then you go around it there, or the 12 o'clock position. And you can either use anterior superior, anterior inferior, or an o'clock position. We're not really all that accurate, especially in correlation with surgical findings. So I think the clock position overly, people who use it really have an inflated sense of their accuracy. So if you use one, I prefer this one: superior, inferior, anterior, superior, anterior, inferior as locations. So looking at these, this comes from an article from UCSD and AJR. Type 1 slap tear is degenerative fraying of the superior labrum. The biceps anchor is still intact. Superior glenohumeral ligaments not involved. and the middle glenohumeral ligament's not involved. And that's the most common ones we see here is normal. A little tiny recess like this, most people believe is normal. Degenerative slap tear here, we can see that the normal superior recess is kind of a curvilinear increased signal intensity with very sharp margins. This is really irregular, and we see signal. The key thing is we see signal going into the superior labrum. So this would be a type 1 slap tear. Type 2 slap tear is one that actually involves the biceps anchor here. And here we can see this is a normal recess. And there's the biceps coming down. There's the labrum. If we go one over here, here's the normal recess here. There's a second linear structure here, which is actually going into the labrum. And we can see that there's abnormal increased signal intensity within the biceps anchor as well. That's the slap tear. And then we have a paralabral cyst associated with this, which the cysts are very helpful in confirming our suspicion that it's a tear. So if you see a cyst associated with it in this particular location, that's highly associated with there actually being a tear. Now, Morgan, an orthopedic surgeon, divide type 2s into 3 types. This is just so you know this. I don't really use this anymore. Type A, the tear is just anterior to the biceps anchor. Type B, it's just posterior to the biceps anchor. And a type C, it goes all along the course there. So this is a typical A, B, and a C. The vast majority that we see, I think, are Cs. And at one time it was thought that the exact location may change the management. And a lot of people did surgeries on these up until about 5 or 7 years ago. Turned out that patients did not do well with this particular surgery. So the vast majority of slap tears now are no longer operated on. So the interest among orthopedic surgeons has waned in this particular area from my experience. However, the term slap tear is still very prevalent in the sports world. And a number of people have told me that whenever athletes come in right now, one of the questions that they or their parents ask is, does my son or my daughter have a slap tear? So most of the orthopedic surgeons I work with right now are interested in knowing, especially in younger athletes, whether there's a slap tear or not, to be able to answer the question of the patient and the parent. However, again, the vast majority of these are not operated on, so it's not generally considered a need to operate unless it involves the biceps anchor, in which case it may need to be operated on because the ones that involve the biceps anchor tend to be an important cause of symptoms, whereas the rest of the slap tears typically are fairly asymptomatic. And here's a type C slap tear. It's posterior. We can see it back there. You can see it coming out. It starts posteriorly, goes through the biceps anchor. We can see here it may even be involving the biceps anchor. And it is involving the biceps anchor, but then it's going further. To be a type 2 means it involves the biceps anchor. So that's a type 2C. Now, associated with these type 2C is a mechanism called a peel-back mechanism, which has to do in athletes when you put tension on the biceps tendon, and then you go through an arc or a range of motion, then you have tension on it and a twisting mechanism, and that's thought to produce a lot of strains at the biceps anchor, which produces a tear of the biceps anchor and a secondary tear of the superior labrum. So if you see a type 2C in an athlete, many people believe it's due to this mechanism. And we're all familiar with Frank Job's different phases of the throwing mechanism, and this is the phase that really, as we've already talked about, is the important one in injuries to the shoulder as well as the elbow, where you have a maximum external rotation and you get impingement syndromes. And then when you go through the throwing process, that's when a lot of the biceps fires and you get tension and rotation on the biceps anchor. So it may be in this phase where you get a lot of the superior labral tears, the type 2C tears. Okay, I'm getting tired of talking again. So Sam, what do you think of this case?
Snap the picture. The anterior and posterior labrum actually don't look normal, but on the sagittal, it looks like well, I don't see the biceps long head tendon either. Um, but on the sagittal, there's at least fraying of the superior labrum.
Which one are you calling sagittal?
Oh, is that on? What is that on the left? Oh, is that
Okay, I think
axial?
superior glenohumeral ligament. This is the superior glenoid here. That's the humeral head. I think these are both axial. This is one higher up, and this is one down a little bit lower.
So there's an anterior labral tear.
So the anterior superiorly, we see a tear here. We see it extending inferiorly here, but we also see it extending posteriorly to above the posterior superior labrum as well.
Yeah.
And then here, with the posterior one, we can actually see there's a paralabral cyst associated with it. Back here. And this was a high-level athlete. And this is a case where the posterior impingement, which was producing the injury to the posterior superior labrum, and he also had a type 2C slap tear, which was probably due to the peel-back mechanism that we talked about. And there's a little indentation here, which is probably due to chronic repetitive impaction in the cocking phase of throwing, though it could also be a traction injury from the infraspinatus insertion, as we talked about before. Okay. Thomas, what do you think of this case?
49-year-old female with shoulder pain. So there's a slap tear, and
What kind?
the biceps tendon is also involved. So that's
so the biceps anchor is actually torn off here. That's a superior labrum.
right. That's a
biceps anchor.
type 4.
So this is a type 2. Well, because it just involves the biceps anchor. At type 4, the tear extends longitudinally into the biceps.
Oh, right. Okay.
Thomas, what would you do with this one?
So it involves the biceps anchor, so they might benefit from surgical management.
Well, 49 years old, over the age of 40, what you do is just do a tenodesis or release it.
Oh, okay.
You don't try to repair these.
Okay, we have tear of the anterior labrum with paralabral cyst, and it's extending. Okay, it's a slap tear. The biceps. I'm not seeing it very well.
We have a big paralabral cyst. Here's what it looks like on the sagittal images and the axial images here also.
Yeah,
so we can see the fluid going through the tear into a paralabral cyst. Here's where the paralabral cyst is located here. This is the joint capsule in this location. So that's, and then here we can see another tear of the superior labrum extending out into a paralabral cyst. So those are type 2 slaps of paralabral cyst. Okay, Sam, what do you think of this case?
Looks like the superior labrum is torn and probably dislocated posterior to the glenoid. And
why do you say posteriorly dislocated?
I mean,
these are
what is that?
These are coronal images. So this is down. We don't really have any posterior images here.
What is? I'm sorry, not posterior. I meant medial to.
Oh, you mean this thing over here?
Yeah. What is that?
This is a fat suppressed image, so that's probably fat that's suppressed.
Okay.
We don't see a good labrum here. It's definitely abnormal, like you say. But what's this? What's all this fluid here? But this is a arthrogram on the T1 fat suppressed. This is not bright. On
it's the same.
on the PD fat suppressed, it's bright.
Yeah. It's kind of far from where I expect to see a cyst, a paralabral cyst. So
here's a T2 image of it.
Okay, here it's extending from the labrum, I guess. Okay, it could be a paralabral cyst, like an intra-articular paralabral cyst.
Well, it's not intra-articular. If it were intra-articular, it would contrast would go into it. So what we're seeing is that contrast is not entering into whatever this fluid collection is, right?
Yeah.
It looks like fluid on the PD fat set and the T2 weighted images, and it looks like it's coming from the superior labrum. And here, if we see, this is it right over here. And as you follow it out, it gets bigger.
Yeah.
So this is a type 2 tear also, and this is a cyst. And this cyst, however, is extending between the joint capsule and the supraspinatus muscle. So this can go anywhere in these locations. This is a relatively uncommon location because you think there'd be high pressure there. So we want to go over here. This is what that black structure was. It was fat there. They usually go over here into the notch because it's lower in signal intensity. But I just want to point this out that you can see it on the surface of the supraspinatus muscle, much more rarely actually into the supraspinatus muscle. Okay. Thomas, what do you think of this case?
So there's a tear of the superior labrum. There's a slap tear, and
so this
looks like
this would be the cartilage or the recess, probably the cartilage. Second is, so this is actually signaling in the labrum, and therefore you're right. That's got to be a superior labral tear. Keep going.
Right, and then looks like it extends to the posterior labrum.
Okay, so we can see it extending back here, and a little bit anteriorly, maybe. Okay. What does this show?
And, maybe a small paralabral cyst posteriorly.
A little paralabral cyst there, and then here we can see. No, sorry. Okay, so that's that. Okay, so now because this is 9/26/07, now the patient came back on 7/17/08.
Right, so it's a year later. I'm still seeing signal in the superior labrum, but have they had surgery or?
Okay, so here's a suture anchor defect right here. So this patient's had a slap repair, supralabral repair,
Right.
those two locations. And there we can see the two suture anchors on the sagittal. So that's a repair of the slap injury. Now, a lot of studies have shown that by doing this, you often over-constrain the shoulder, and the symptoms can get worse. So this is a less common surgery than it used to be. But if people feel that it's unstable enough or that there's significant symptoms that may be associated with the biceps in a younger individual, people still may do slap repairs.
Okay, we have CT arthrogram, and it seems that there is contrast going through the superior labrum. Yeah, we have a superior labral tear.
The axis.
Okay, it's going posteriorly as well, so it's like a slap tear.
Density in there. So that's just a CT arthrogram also showing the slap tear. Okay, so that's kind of type 2 slap tears. A type 3 slap tear is a bucket handle tear of the superior labrum with a little bit of displacement, but no involvement of the biceps anchor. So here's an example. This is the superior labrum. It's torn off. It's displaced. We're seeing fluid going between the biceps and its attachment. In this one image, we don't have the anchor, but the anchor was intact in this particular patient. So, Sam, what do you think of this case?
There's a tear of the superior labrum. I think in this case, there's involvement of the anchor and biceps tendon. I mean, the signal at least inside, if you signal inside the biceps tendon.
The biceps anchor looks normal to me here. Looks like it's normally it attaches here. Right? The anchor is this right here.
Okay.
And the tear looks like it involves the labrum, but does not extend into the biceps. And then we can see the tear extending here a little bit more anteriorly. On axial images, we can see it extending anteriorly as well. And then we finally get down to a normal. And this was a type 3 slap. Again, I don't think types are all that important anymore. Back in the days when people were talking about treating the people were thinking that maybe the different kinds of SLAP may be treated somewhat differently, but that really hasn't panned out. And then there's the type 4 SLAP tears, and these Snyder described as the most symptomatic of all SLAP tears. And this is where we have a tear of the superior labrum with a longitudinal extension into the biceps tendon here. So here's an example where we can see a tear involving the superior labrum. There's the biceps anchor. That's on 2/22/05. The patient came back a few years later, and we can see the tear here, a little bit of displacement of the superior labrum, and now we can see a longitudinal tear, this tear extending into the biceps tendon here, longitudinally. So that's a classic type 4. And here we can see extension of the fluid along the biceps on the sagittal images. So that would be a type 4. Okay, see, Thomas, what do you think of this one?
So 2 coronal views, and
that's the biceps. In case you couldn't tell, this one slice plane. You could follow the biceps, up through here, and when you follow it on the other images, this is the biceps tendon itself right here.
so yeah, it doesn't look. I'm not sure if it's continuous. If it's
And so what we found is that there is no black structure that really looked like a superior labrum either. And at surgery, this was a type 4 SLAP, the degenerative type tear and maceration of the superior labrum, and severe degenerative disease and partial tearing of the biceps, the longitudinal biceps here as well.
Okay, so we have the superior labrum is very degenerated. So there's tear, degenerative tear. Yeah.
What about the biceps anchor here?
So the biceps anchor, if that black line is part of the biceps.
It's part of it.
Yeah.
If we get the axial images, we can see the biceps is very degenerative.
Yeah, it's very
and
small.
Signal more distally. So that's the biceps there. And this turned out to be a superior labral tear. And then really a degenerative tear extending all the way down the biceps here. And they ended up treating this with, as John said before, they just resected the biceps and did a tenodesis because these can be very painful. I don't know if I told you the story about a very famous, well-known NFL quarterback who was a multi-year all-star player in Denver, Colorado a few years ago. I won't name any names. I think everybody knows who I'm talking about. He had severe pain toward the end of his career and was evaluated multiple times. And he didn't really have a discrete rotator cuff tear, so nobody really wanted to operate on him since he had a huge contract. Then he was warming up for the Super Bowl, and he felt a big pop in his shoulder. And all of a sudden, all his pain went away, and he won the Super Bowl after that happened. And then when they redid the MR scan, what had happened is he had a severely degenerated biceps tendon, but right before the Super Bowl, he tore the tendon. It distally retracted. All his pain went away, and he was really angry that for 3 years they didn't go in and operate on him and cut his biceps tendon. Because he actually played a couple more seasons. He was thinking about retiring after the Super Bowl, but since his shoulder pain went away when his biceps ruptured, he went ahead and played a couple more seasons. So these can be, the biceps can be a very important source of pain, and it's one that often is unrecognized because it's hard to see arthroscopically. You can't really evaluate it very well on arthrography. As we know, it's commonly associated with displacement into the subscap here, but so evaluating the biceps can be important. And see, are you next? Who's next? I don't know who's next, but Sahar will take it.
Okay, we have, I don't know, I think it looks like the supraspinatus is torn.
Supraspinatus too there.
Yeah, and we have a lot.
Delamination, a little bit of retraction here. then when we go into the superior labrum,
Yeah, we have a lot of abnormal signal in the superior
a lot
labrum,
of
and
increased signal intensity. It looks like there may be some linear stuff there in the biceps tendon, so we're concerned about that. So then this is the next cut. This patient's in internal rotation, as you can see, because the intertuberous groove is anteriorly located here. So this is the biceps tendon.
Okay, it's torn.
So we've got severe degenerative disease. This is the sagittal image showing the biceps tendon. So we have a superior labral tear with signal extending into the long head of the biceps tendon. So this would be, we could call this a type 4 slap tear. Again, I don't use the types anymore, but I would describe this as a degenerative tear of the superior labrum with degenerative disease and partial tearing involving the biceps anchor and the interarticular portion of the biceps tendon. I think in the intertuberous groove it was more normal. So, and these can be very symptomatic lesions, as I just described to you. Let's see. Why don't we stop here, and we'll pick up so those are the first 4 types of slabs. Those are the ones that almost all orthopedic surgeons recognize. And then let's go into the more esoteric varieties of slap lesions on Monday. Okay? Any questions?
Thank you.
Thank you.
Alrighty.
Have a good evening, guys
Great.
See you.
Have a good.
and girls.
Yep.
See you Monday.
Alrighty. See you, John. Thanks.
Have a good lecture tomorrow.
Thank you, John. I appreciate it.